think this is where we stopped the last time, right?
Yes, ma'am.
Okay. Okay. So we'll quickly continue from there. The last time we talked about we ended with the 5 keys to safer food by the WHO. So we'll continue from this. So since we didn't take much of the theoretical background, I'll try to put in a lot of theory so that we're kind of killing two birds with a stone. So we'll just be saying some things along the way so that it gives us a broader base. So how would we describe this particular picture? I know today we'll have to be very fast so that we can cover much. So if one person can just say something, we'll move on. Like, so sorry, 90 minutes behind schedule. Sorry, can we see the picture? Oh, it's not moving there. Hello?
We can see, but please let's all be talking, okay? Dr. UC, Abdulaziz, Ujunwa, Judith, let's be talking, okay? Let's be responding. Thanks.
Just anything and then we move on. How would you describe this picture? I know it might not really be clear.
I can't see the picture.
Oh, you can't see the picture?
No.
I think you have moved past the slide. Maybe we should go to the slide before.
What about now? Is it even moving?
No, it's what we can see is the core message of the 5 keys to safe food are keep clean. That's what we can see.
Is what? Okay, maybe I'll not put it on slideshow then. I think this way it's moved.
Okay, yeah,
Okay,
yeah.
so this is the picture I'm talking about.
Yeah. This was we last time.
So can we just say something so that we can run very fast? So I don't know, should I just have a monotonous, be a mono? Anything, please.
Someone trying to discard trash.
Sorry. Hello, I didn't get that. Okay, just to be fast, I'll just go on because it's over 2 minutes. So it's a woman trying to dispose of refuse, and if I look at this environment, one, if you see the dustbin or the drum she's trying to dispose in, it has a lid, and then she's tying the refuse. This is a house, it looked like a house. She had finished sweeping and all. There's a broom beside her there, and she's tying it in a black lining bag. So I would say safe disposal of refuse or sanitary disposal of refuse. But if you look at the another image, let's say by the right there, imposed on this same image, we can see the insanitary disposal of refuse, where you see open dumping. You have a woman standing by an open dump there. So the larger image, I would say, is sanitary disposal of refuse, and that can entail many things, but then I think I would stick with that. So when we are talking of refuse or waste, when we are talking of waste, I mean, these are things you would think about. What are the types of waste?
Solid waste.
Okay, solid waste, also referred to as So we have done this before, so I'm just trying to use this to like help us get a good start. Solid waste is also referred to as,
Refuse.
okay. Then the other type of waste is,
Liquid.
Sewage.
okay.
Liquid or
And then
sewage.
the liquid waste is referred to as,
Sewage.
okay, good. So when you're talking about sewage disposal systems, they can be classified into two. Please, what are they? Broadly. So, like I was talking about when I was looking at the picture, it can either be a sanitary method or a non-sanitary method of waste disposal. Okay. So I just have them like at the end of it all, I'll just send this to us. So a liquid waste, it can be sewage or sewage. And the last time we talked about the difference between the sewage and the sewage, majorly the fact that sewage contains excreta, but sewage is majorly waste from places like the kitchen, that does not contain excreta. It has its own way of safely disposing of it too, and shouldn't just be thrown, out openly the way some people do, because that can also pose a risk, help vectors to breed and all that, and pose risk to our health. So when you're talking about methods of waste disposal, it can be sanitary or non-sanitary method or insanitary methods. So we talked about all this the last time. We said the sanitary ones are, the composting, the sanitary landfill, incineration. The one that I use depends on where the waste is coming from. Take, for example, in healthcare system, many of our waste, we incinerate it because of the risk of contamination with hazardous material, especially when it has to do with the anatomical parts and some of those other things. They're actually incinerated, then buried after that. So when you talk of methods of waste disposal, I know I don't know if I think we went through some of this, but all the same, just for knowing sake, I'm trying not to make us go deep into it, but just to know some basic things that if asked, at least you'll be able to list. So one is that I said it can be treated, their sewage treatment. I talked about the WUPA plant, and I talked about some mini estates having their own sea outfall, river outfall. Those ones just means you discharge into a sea, discharge into the river. Land treatment, where they're used for farming, irrigation, oxidation ponds, and ditches. So basically that is that. I think we talked about some of this, so I'll just move on quickly. So remember there was a time when we're talking about vectors. I was saying that there are two types of vectors. A vector can be a mechanical vector, or it can be a biological vector. So for example, if you're talking of mechanical vector, you talk of things like housefly, cockroaches. They are mechanical vectors. What it means is that it's not as if they have the biological agents inherent in them, but they carry it on the surfaces of their body and move it from place to place. So that's how they contaminate our food, contaminate our water. What they do is that they carry those infective agents on their body, but not inside their body. So those are the mechanical vectors. And when you talk about biological vectors, why I'm going to this is because we're talking of refuse, and we know that waste, which is solid refuse, which is solid waste, when disposed of in an insanitary manner, it's a breeding place for vectors, So when you talk of biological vectors, there can be what we call the propagative, the cyclopropagative, and developmental. I want you to just know maybe one disease from here, and it will help you remember it when you are asked. One, when you are saying propagative, is that the organism only multiplies in the body of the vector. That is, the infective agent only multiplies. An example is rat fleas, which caused the Black Plague. Then what it does is that the the organism, the bacilli, just multiplies, but it doesn't undergo any developmental, let's say, stage within the rat. Within the rat fleas. So that's what happens. Also, another example is yellow fever. So the effective organism only multiplies within the Aedes mosquito. There's no let's say developmental maturation or any change of form. It's just a change of number. Okay, just know it this way. You can either have a change in number or a change in form. When you only have a change in number, that is propagative. When you have a change in number and in form, that is cyclopropagative. When you have a change only in form, that is cyclodevelopmental. I just pray it makes sense to you. So an example of cyclopropagative would be the malaria parasite Plasmodium. We know that it changes, it undergoes various developmental changes as well as number while in the mosquito before it finally gets to the salivary gland of the mosquito. So malaria parasite is an example of a the mosquito, like the Anopheles mosquito in this case, is a biological vector that undergoes is a cyclopropagative biological vector. Then the filarial parasite only changes form, that is in guinea form. In guinea worm, it only changes form but does not change in number. So those are just 3 examples, so that when you're faced with other ones, you can use that to deduce it. I just hope it wasn't too confusing. So this is still refuse being openly dumped and all that. So when we see this image, what comes to mind?
Hello.
Sorry?
Hello.
Sorry, I didn't get that. So sorry.
Hello.
Clean water.
Did you say water or what? Sorry, I'm trying to get what you're saying.
Clean water.
Okay, clean water. Okay. So water that have the characteristics that we drink, what do we call it?
Colorless, odorless, tasteless.
Okay, what is that kind of water called?
Purified water.
Have we heard of potable water? Hello?
Yes.
Okay, so potable water will have those characteristics you've called, right? It is odorless, it is colorless. So sorry, excuse me. So it's what we call potable water, and it has all those characteristics you've called. So it's water that is safe for drinking. So can we say what are the uses of water?
Cooking, domestic purpose,
Okay,
industrial
okay,
purpose,
okay,
for transportation.
okay. Okay, so this is what I have written down. So my reference is Obionu. So these are the basic uses of water. Domestic or household use. So for our bathing, for our cooking, for cleaning in the house and all that. Then the industrial or commercial use, like we talked about, I think if the transportation will likely fit into this group. Then agricultural purposes like irrigation, recreational purposes like swimming, using it for sports, water skiing, and the rest of them. Then environmental purposes, they said like a garden or those artificial lakes, or those that kind of are appealing to our sight, and make our environment beautiful. So these are the uses of water. So I'm going to run very fast, so I'll move now. So can you tell me the other characteristics of water? We've talked about some already. I hope I'm audible.
Yeah.
Okay. Can we quickly run to the other characteristics of water? Okay, let's run. So a potable water should be colorless, odorless, should be transparent, should be free from impurities. And apart from this, basically, when you are talking of water, what you could do is to classify it into three things. There are three qualities under three basic broad headings. There could be physical characteristics, there could be chemical characteristics, or biological characteristics. So when we are talking of the physical characteristics, we are talking of things like the color, the odor, the turbidity, which has to do with the transparency we are talking about, being free of suspended lipids, suspended solids and all that. Now, when we are talking of chemicals, it will now have to do with all these mineral salts and all that. There's a particular reference range. I won't bother us with much, just know these basic ones, but if we want to know more, we can check out Obionu, still the page 22 that I talked about. And then potable water should be free of harmful microorganisms, whether bacteria or viruses. It should be free of it. So for any of us who is interested in the detail, these are the reference ranges, so we could check them up later. But I don't think it will be much important. So you should just know the basic. But most importantly, you should know that potable water should have zero pathogens, whether bacteria or viruses. So, have we heard about chlorination of water? Okay. So, which is the most important part of during chlorination? Which part of it accounts for the major germicidal action? Okay, so I'll just run us through it. So the disinfecting action of chlorine in water is due to one, the hypochlorous acid, which is a HOCl. This is actually the one that plays a major role in disinfection. Why the chloride ion, sorry, why the hypochlorite ion has a minor role in disinfection. Then one other thing to remember is that it is only chlorine that has what we call the residual germicidal action. When you use other agents such as ozone or the UV rays to disinfect water, these ones do not have residual action. So most times when our water is being redistributed for use, an extra amount of about 0.5 to 1, is left in the water to further take care of any germs also that the water comes in contact with along the way while it is being distributed. So basically what I'm saying is that you can have like two questions from here, like which part of the chlorine plays the major role in disinfection, or which accounts for the major disinfecting action of chlorine, and then which of the following chemicals have a residual germicidal action. So since we are still talking of water, and like I said, we've not done much of theory. So I'll just quickly talk about the hardness of water. Basically, there are two types, and it can be temporary, or what is called carbonate hardness, or it can be the permanent hardness, which is the non-carbonate hardness. So basically, the temporary hardness are just salts of bicarbonate, whether calcium or magnesium. But salts of sulfate, chloride, nitrates, they are permanent hardness. So I've just added a few notes under there, but I think we should just know as basic and that as that. Sorry, it might be quite broad because it's actually meant for postgraduate. So there's a lot there, but then let's just know the basic. So
Let's see the slide.
sorry.
That's like temporary and permanent.
Okay, you want to see this slide?
Okay.
Okay, so this is the slide. So like I said, it's just temporary hardness, permanent hardness. So salts of bicarbonate are temporary hardness, while salts of sulfate, chloride, nitrates are permanent hardness. So, and the measurement is in milli equivalent per liter of calcium carbonates, which is equivalent to 50 milligram per liter of water. Okay, so can I move on? Can we move on? So so basically from this slide, what I just want us to take note of is that the water for drinking should have moderate hardness, which is about 50 to 150 milligram per liter of water. That is 1 to 3. So greater than 3 or less than 1 is not good for drinking. And it's hardness of water, or that moderate hardness, is important for preventing cardiovascular disease. So that's why I just brought up this slide. So that's a point to take up from this particular slide. So how do we remove hardness from water? For the temporary hardness, easy. We do it every day in our house. Most times I notice that the borehole water here in my house, when I boil it, I notice over time there's this whitish stuff that builds up in the kettle. So that is the hardness being removed from the water. So for temporary hardness, it can be removed by boiling, addition of lime, addition of sodium carbonate, and a hermetic process. While for permanent hardness, we have addition of sodium carbonate and then base exchange process. So please, what comes to mind with this picture?
Latrine.
Hello? Sorry, I'm just not trying to make you uncomfortable, but I just believe that if it's interactive, we would learn more and would enjoy
Pit
it
latrine.
more. Pit latrine, yes.
Latrine,
Can we see
toilet.
that? Okay, yes, toilet. Can we see that structure by the side, like a vent?
Yes.
Okay, so that makes it a bit, at times, when you want to answer these things, if you can, or if you know the specific, yes, go as far as you can and be specific. But if you don't know the specific, play safe and use the broad terminology. You just say pit latrine. But if you see that structure, there is actually a VIP, because of it's a modified form of the regular or traditional pit latrine we know. So it has this vent that helps heat and odor to escape. So that makes it different from the traditional pit latrine. So if I were to describe it, I'll describe it as maybe a girl about to use a VIP latrine, something like that.
What's VIP, please?
Ma?
What's VIP?
Is ventilated improved.
Okay.
Hear that? Hello?
Doctor, you said ventilated improved pit latrine.
Yes, ventilated improved pit latrine. So it's an improvement over what we know. And I said the difference is this structure that you are seeing there, which helps odor and heat to escape. So by doing that, it will minimize vectors breeding in it. So let me just read a reference from here so that while we quickly go on. So basically, for the pit latrine, it has like 4 basic structure in it. One, this superstructure we are seeing, which is like the house. Then this ventilation pipe or vent.
No, doctor, we can't hear you.
Shivanuki, we can't hear you again. We've lost audio from you.
I'm so sorry. I was muted and talking. I'm so sorry. So sorry. I said the pit latrine is, the VIP latrine is ventilated improved pit latrine. That it is an improvement over the traditional pit latrine, and that it's made up of 4 basic structures. That is this superstructure, which is like the house, then this vent pipe, then there is a floor under which this superstructure is sitting on, then there is a pit beneath. There's a pit beneath it. So those are the 4 basic components of the ventilated improved pit latrine. So, and I said that the basic disadvantage of this is that it overcomes that nuisance of flies. Like, what is common with the traditional pit latrine? You see maggots, flies all over the place, the smell, odor. But this overcomes that disadvantage. Okay. So this kind of takes me to school health. Like, how many students per urinal? Like, how many boys per urinal should you have in a school? Let's say if you're in a school of 500, how many urinals should they have? Let's say you have 500 boys. So we're talking about like the WHO standard now. Don't know if anyone has an idea. Hello, sir. Am I still audible?
Maybe 10.
How many words?
Maybe 10. I'm not sure.
Okay, somebody is saying something, but I'm not getting her.
I said maybe 10, but I'm not sure.
Okay. Thank you so much for the attempt. So So this is what you should have. So this is just a component of school health or a healthy school environment. I just picked like one of it. There are several other things. But then for the urinal, for the boys, you have 1 per 60 students. Then when you talk about the latrine now, like where this girl is about to go in, you talk of 1 per 100. But then there should be separate. So let's say in a school where we have say 500 students, maybe say 450 boys, 50 girls, or something like that. It doesn't mean that they should just have say 5 latrines or something, but that you have to put the fact that there are different sexes within the school into consideration. So because of that, you may have to build like maybe 5 to 6 latrine, but then that of the girls must be separate from the boys, because we know the needs of the girls differ from that of the boys. So I won't want to derail too much, but when you talk about menstrual hygiene and all that, this is implicated. They will need a place that is comfortable for them and separate from the boys, where they can carry out their hygiene, especially menstrual hygiene. So it's important for that. Then when you talk of toilets, maybe the water system and all that, you should have 1 per 40 girls and 1 per 60 boys. So you should, most times, just have it in mind that the needs of the girl may be slightly different from those of the boys. So you have to take that into account. So this next picture, what comes to mind? These are like, will I say preschoolers or that's using water, and seem like to be a dirty water in a bowl. So what comes to mind when you look at this?
Hand washing. Hand washing is a
Chlorella.
dirty.
I'm so sorry. I don't know whether it's the network from my end. When you speak, I don't hear, and I'm just hoping
Chlorella.
I'm audible. Okay, yes, cholera. Uh-huh.
What else? That's it,
Okay,
coming.
okay. So yeah, one of it to be cholera. But when you see water like this, for me, what comes to my mind is water-related diseases, and we could
Okay.
typhoid. Yes, yes. So we could discuss so many of them. There are so many. So sorry, Sophia, I didn't get what you just said. I'm so sorry. You're talking, but I can't hear you. So sorry about that. I didn't get that. So what comes to mind are the water-related diseases, and always I like using code because it helps me to remember better. So we talk about basic. That is the waterborne. For the waterborne, the cholera you talked about falls into this group because the infective agent is in the water itself. Then the water arthropode, which means the water provides a place for them to breathe in or breathe near it. So malaria, and the rest of them, or even onchocerciasis, and all that. Then when you talk about water shortage, especially when I see these children washing their hands, in that comes to mind for me. So they could have scabies, they could have trachoma, maybe because of lack of water to wash their faces and all that. And we have the water impounded diseases. This one basically is that the you have things like schistosomiasis, where the intermediate host lives in water, and then the water chemical constituent diseases, which can either be excess of the chemical or shortage of the chemical. So just something brief for us to go through it.
Please, can I see the last slide, please? Can I see the last slide?
Okay. So the last one is the water chemical constituent diseases. Okay. Do I move?
Yeah.
Yes.
Thank you.
Okay. So for the waterborne, this is what you have. Viral could be hepatitis A, hepatitis E, polio, rota. Let's particularly take note of that. Just to remember that rota is now one of the routine immunization. Rotavirus vaccine is one of the routine immunization now on our national program on immunization. So they are giving routinely now. Starts at 4 weeks and then 4 weeks apart. So let's just take note of that. And we have bacteria, like we talked about, typhoid, paratyphoid, bacillary dysentery, E. coli, diarrhea, cholera. Then protozoa, amoebiasis, giardiasis, helminths too, helminthic diseases, parasitic, roundworm, threadworm, whipworm, hydatid disease, all that. Then leptospiral, Wills disease. Remember leptospirosis? This time that there was an outbreak where things that were stored, like drinks that were stored in the warehouses, rodents urinated on them, and there was this spread then that we had a lot of, I can't remember what year exactly now, but there was a lot on it then. And you could have such epidemics when you have floods happening too, because this urine and all that of animal
So we can't hear you anymore.
Oh God. I'm so sorry. It happened again. I've been talking for. I'm so sorry. I've been talking for so long, not knowing I was muted.
Well, I think it's for just like 30 seconds there, or let's say 1 minute at that. That's 1 minute that we couldn't hear you.
Okay. Please, once immediately you notice you can't hear me, please just let me know. Sorry. I just mute whenever there's a disturbance before unmuting, and I think I forget to. So I say what comes to my mind when I see this is water-related diseases. Like one of us have said cholera, and I said aside cholera, there are so many other diseases that could occur. So, and for me, I love cold. So, what I remember is water basic. That is waterborne, water arthropod, water.
We can't hear you. We can't hear you again. We can't hear you.
Hello, sorry. Yes, I think it's the network this time. Can you hear me now?
Yes.
Okay, so sorry about that. I think it's a network this time. So I said, I prefer to use basic, which is waterborne, water arthropod, water shortage, water impounded, and water chemical diseases. And these chemicals can be excess of the chemical or shortage of the chemical in water. Are we still hearing me? Am I still audible?
Yes.
Okay. So we move on. So for the water,
Out of service. We can hear you.
for the viral, we have hepatitis A, E, polio, rotavirus, and diarrhea diseases in infants. And I said, let's particularly take note of rota. Rota has now been included into the routine immunization. I think it was this year. You can please check it up online for the date. So first at 4 months, then 4 weeks, then 4 weeks apart for the second dose. So then bacterial diseases like typhoid, like you mentioned, paratyphoid fever can be caused by bacteria, bacillary dysentery, E. coli, diarrhea, cholera, like you mentioned. Then the protozoal waterborne diseases are amoebiasis, giardiasis. The helmintic, we have the roundworm, threadworm, whipworm, hydatid disease. Then leptospirosis or Weil's disease is also a waterborne disease. And I said there was a time when there was an outbreak. Remember, they said drinks stored in warehouses, rodents urinating on them, and people coming down with leptospirosis. Most of us are asymptomatic when it comes to it. I think about 80%, but a few individuals come down with the severe form of the disease and may likely die. So that is that about that. And this, like every other communicable disease, you could have outbreaks of this during flooding, when the urine of animals come in contact with water bodies and water in the house and all that contaminates water during flooding. And so you could have outbreaks of leptospirosis during those kind of times. So the water arthropod diseases, we have that by Anopheles mosquito. This one is due to the arthropods breeding in or near the water. So we have Anopheles mosquito causing malaria. Then I said the Aedes mosquito. Remember the code I gave us the last time? I don't know if it was this set. CDYZ for Aedes. That is chikungunya, dengue, yellow fever, Zika virus are all caused by Anopheles mosquito. Additionally,
Please say it again.
CDYZ.
CDYZ.
Yes, chikungunya, dengue, yellow fever, Zika. So additionally, you could have the Japanese bee encephalitis and the Chiasanu forest disease. So we can maybe stick to the popular ones, like I said, the CDYZ. Then simulium fly or the black fly causing onchocerciasis. They live in fast-flowing water. So they lead to what we call river blindness. That is onchocerciasis. I'll try and put it in brackets so that I remember that. That is river blindness. They breed in fast-flowing water. Then fly leads to, that is the Glossina species, causes the African form of trypanosomiasis. The African form of trypanosomiasis is also referred to as sleeping sickness. Let me just give you the other name. sleeping sickness. So okay. So just to take note of that, there's an American, this is qualified because there's an American form of the trypanosomiasis, which is referred to as Chagas disease. That one is caused by Ludwig bug. I wouldn't want to go too much into that, but just have the idea, peradventure you come in contact with that. Then there's what we call the water shortage diseases. These ones are due to inadequate water supply for basic hygiene. So we have those caused by chlamydia, like the trachoma that I talked about. Just for the theoretical basis, what is practiced for trachoma is what we call the safe strategy. Safe strategy, safe as in SAFE, where S is, there's this complication where they have a, what do you call it now? Is it, I'm not sure if it's entropion, but I think theirs is ectro, not entro. So where they need surgery to correct it because it could lead to permanent blindness because of continuous friction on the cornea, and all that. Because they have like a kind of is it? I think it's inward turning of the, because of injury and scarring with healing and fibrosis, the eyelid tends to kind of turn inwards such that you have the lashes rubbing on the cornea with continuous friction, leading to injury and even, healing. I know when the cornea when it heals, um, um, you may have some kind of opacity and because of scar tissue, and that could lead to blindness. So that's the complication you have there in trachoma. So one of the part of the safe strategy is surgery. Then there's antibiotics in trachoma. Then there's facial washing, and that's why sufficient water for personal hygiene is very important, because this disease thrives in area where there's insufficient water supply, because the women or the children are unable to wash their face. So what happens for the control is that these school children are encouraged to wash their face in the morning, even if they don't have it to like completely bath, they should wash their face. Because what happens is this: the young children or school children are the carriers of this disease, and then they transmit it to their mothers, and then you find out that it gets complicated and the mothers come down with blindness. So part of the safe strategy is E, which is environmental sanitation. Remember when we talk about vector control the last time, we said the most important component of vector control is environmental control. That is the most important, environmental control. We talked about physical, we talked about chemical, we talked about biological, but the most important is environmental. So when you control your environment, you take care of a large percentage of the problem. But then remember that what is being ideally practiced now is what we call integrated vector management, where you have all the strategies, all the forms being carried along, which means that if I want to control mosquito in my house, so sorry, I had a call coming in. So I said what is being practiced is integrated vector management. So let's say if I want to control mosquito in my house, just to give an example for us to remember, I would have mosquito net in my house. I would still use insecticide. So sorry, a call keeps coming in. So I said, so if I want to, talking about integrated vector control, for example, if I want to control mosquito in my house, I have physical methods like my netted windows. I could use mosquito net that is impregnated with chemical that is permethrin. I could use insecticide still in the same house. Then I have to keep my environment clean, ensure that there are no pots left open or water tanks left open. Remember, we said that Anopheles is a sophisticated mosquito, so it likes clean places. So when you leave open water like in tanks and all that, is a good breeding site for them. And also outside, ensuring that the grasses are cleared and there are no stagnant water bodies. So all that. So I've just not done one form of control, but used several methods of control to eliminate the vector. So bacterial for water shortages, fungal infection, ringworm, protozoa, calaeza. This calaeza is a complement what do you call it? Is leishmaniasis. As we go on to, we'll see more on it. Then mites like scabies could also result from shortage of water. So we'll quickly run. For water impounded, diseases are due to presence of aquatic hosts. Example is the snail for schistosomiasis. Please let's take note of the various species of this. Maybe not necessary. Let's just know that snail is the intermediate host for transmission of schistosomiasis. I remember that there's what we call terminal painless hematuria is pathognomic of infection with Schistosoma hematobium, terminal painless hematuria. So for the cyclops, they are intermediate host for guinea worm, then fish tapeworm for paragonomiasis. Okay. Am I still audible?
Yes.
Hello? Hello, can we still hear me?
Yes.
Hello?
Yes, we can hear you.
Constituent disease, like I said, it could be excess of the chemical or shortage of the chemical. For when you have fluoride of less than 1 milligram per liter in drinking water, it could lead to dental caries. But when you have high levels of it in water too, it could cause what we refer to as fluorosis. There's this mottling of the dental enamel that you see. Those of us that are from Jos or have schooled in Jos will be familiar with this. You see this, like their teeth are opaque, like whitish with some brownish stuff on it. That kind of mottling. So that is what you get in that. Then deficiency of iodine, you have goiter. Then cyanosis, when water bodies get infected with fertilizer. The fertilizer contains nitrates, and this can lead to cyanosis in infants when such water is used for them. So as that happens because of the cyanosis is due to hemoglobinemia. Then remember we talked about, when I was talking about hardness of water, I talked about cardiovascular diseases. So you need a moderately high water of about 1 to 3 milli equivalent for drinking to prevent cardiovascular disease. So please, what comes to mind when we see this?
A rabies dog.
Rabies.
Hello, are we still here?
Rabies. Rabies.
Hello?
Yeah, we
Rabies.
can hear you. Can you hear us?
Can you still hear me?
Yes, can you hear us?
Hear you.
Okay, can we hear me now?
Yes, can you hear us?
Okay, I hope I've not been muted all the while. Have we, all the one I talked about, water-related diseases, do we hear them all?
Yes.
Okay. So what comes to mind when we see this?
Rabies.
All right, thank you so much. So rabies is what comes to mind. This like a rabid dog. Um, so management of rabies, any idea? What should one do?
I think first of all, you know whether people know like if the dog has been vaccinated or not.
Okay.
I don't know. Can you hear us? I don't know if you can hear us again.
Sorry, I
Can
didn't
you
hear the
hear
last.
me?
Okay, I can hear you now, but I didn't hear the latter part. I heard you first of all have to find out whether the person is vaccinated or not.
I don't know if you can, I don't know if it's from my network. But can you hear me?
I can hear you now.
Okay. I can hear you now. I said the first thing you check if the dog is vaccinated or not. Like you have to know like the owner. Then can you hear me?
Yes,
I
I
don't know.
can hear you. I
Then
can
you
hear
take
you.
the
I
patient.
heard that part.
Then
Um,
okay. Then you take the patient to the hospital. Therefore, they'll admit the patient and do the ABC resuscitation. And then the next thing they do is to give the anti-rabies vaccine. And they is given in 5 doses: 0 day, the third day, the 7th day, the 14th day, and also 21 days. And then you give the anti-tetanus serum, and also you give antibiotics. So if while giving the anti-rabies and after like 10 days, if the dog does not, so if I think if the dog does not die after 10 days, you can then stop the anti-rabies vaccine. And anyone who has this rabies, you have to nurse them in a dark room and then give a pain relief. That's all I know for this.
well, thank you so much. You've actually said a lot. You've actually said a lot. Okay.
Thank you.
So one, immediate post bite, um, whether the dog is vaccinated or not, there are some local things that you'd have to do, like um like you have to clean the area of the wound with water and soap um for like 5 to 10 minutes under running water. No matter how the laceration is, whatever it is, the aim is not to suture at that point, you know. Then you talked about observing the animal for 10 days. Yes, that's part of it. Then worthy of note is that you can see an area is rabies free if there is no case of rabies or in man or animal for like 2 years, and these are places where they are rabies free. So talking about the vaccination now, when this happens and the person comes to emergency, you would want to know, apart from maybe asking the owner whether the dog has been vaccinated, over time, you'd also want to know whether the individual who is coming to you has been vaccinated before now, or take care of some things. And this will help you decide the kind of post-exposure prophylaxis to give. So let's look at the contact first. If it's just touching or licking, where there's an intact skin, there's no broken skin or anything, you may not need to give the PEP, but if there is nibbling of uncovered skin, minor scratches or abrasion without bleeding, you still have to do some form of wound management and also give the anti-rabies vaccine. Then when you have multiple or single transdermal bites and all that, yes, you would do wound management, you give the immunoglobulin, and you give the anti-rabies vaccine. So I know why we give that, which means in this individual, we are giving both passive and active immunization. So please, from these two, can we tell me which is passive and which is active? Hello? So I don't know if you got my question. I say in this, for the rabies immunoglobulin and anti-rabies vaccine, which of them is passive, which is active?
I think immunoglobulin is passive. The other one is active.
Okay, thank you so much. So the immunoglobulin is passive because what that means is that you have preformed antibodies being given to the person. So the idea is that peradventure, the toxin is already formed. So peradventure, you have already formed toxins and all that. That will quick take care of it, you know. And then the active is the anti-rabies vaccine, which means that as it's given to the individual, most likely is an antigen or part of the antigen that is given to the person. So the person actively, the immune system of the individual is the one that produces the antibody. So that is the active immunization. So it's the active form, So if we look at it now, the one that is likely to work faster or start working first is the passive. But the thing about passive is that it does not work as long as the active and may not be as efficient as the active. So I
Sorry,
just want
what
to,
if the person has been vaccinated? Do you still have to give the vaccine?
no. So that's my next slide. If the person is vaccinated, you may not have to go through the whole number of vaccine, whether the 4 or the 5 times, because whether you give 4 or 5 times depend on whether you're using the intramuscular or the intradermal route. So I just have them above here. There are those that can be used as intradermal, there are those that can be used as intramuscular. So for a post-exposure prophylaxis in vaccinated individual, you can just give for day 0 and day 3. While for pre-exposure, but then if in our setting, at times people don't once they are vaccinated, at times people don't even take it. At times they just watch to see, this in our own climate, cost has a lot to play. I've had a case during my house job where somebody came in, he didn't have the money to pay, and I'm so sorry it has happened again. So I said, for the already vaccinated individual, ideally, the person should get for day 0 and day 3. But this may not be the finding in our setting where cost is a major constraint. So most times when we ask, has the dog been vaccinated? And then we wait for the 10 days. Some people they can't afford it. They just wait for the 10 days and see what happens to the dog. And if they are fortunate, nothing happens to the dog in 10 days, they know they are free. So, and whether it's the 5-day regimen or the 4 regimen depends on whether it's intramuscular or intradermal. The intradermal gives the 4-day regimen, while the intramuscular is the 5-day regimen. So I just have them there, the names of the various regimen given over there. So for the post-exposure prophylaxis for all people that are already vaccinated is just day 0 and day 3. Then for pre-exposure vaccination, who do we think are the group of individuals that should have this kind of vaccination? Pre-exposure.
Those that have not been exposed, probably they have dogs.
Then maybe dog keepers. Who else?
Hunters.
You said? Sorry, the last person, I didn't get what you said.
So hunters.
Sorry, the network is quite terrible. Okay, but so we can go ahead. The group of individuals that should have this pre-exposure prophylaxis, which is actually 3 doses: day 0, day 7, day 21, or day 28. So the kind of individual that should have this exposure are people that have higher risk of dog bites. So, like you said, those that maybe probably keep dogs as pets in their houses. 2, veterinary doctors, those that work in like zoos, farmers, some individuals like that. And what you are looking at, remember too, that it's not just the dog, there are other animals, but people that are generally in contact with wildlife should actually get vaccinated, get that pre-exposure prophylaxis. So, for the first person who had asked about those that have been vaccinated for post-exposure prophylaxis, I hope I answered your question.
I have a question.
Okay, please go ahead.
Are rabies vaccines readily available in facilities?
That I would tell you that it depends on the facility in this country. For some, you might have to send relatives out to go and scavenge, maybe you get a because one is not a common, sorry to say, I would say it's not a common finding. And most times people, you look at, you do some kind of cost analysis or something before you stock some things. Dog bite is not an everyday thing, just like snake bite and the rest of them. But what some people do is that you have contacts of, let's say, pharmaceutical company or some kind of source that have that vaccine. So when they come like that, you just direct relatives to them to get it and bring it to you so that you can administer or something like that. But I don't know from the veterinary doctor's end, I don't know how common it is for them. But I think in hospital setting, in some of our places, or I would say most places, it's not that readily available. I won't say it's readily available. For the two instances I've had, in fact, one, the person did not get it because we not even afford it. Then the second one, I don't know if the person was able to get it. So I think that's just what I would say.
Okay, sorry, I have a question. Aside from cleaning the wound and giving vaccine, both active and passive, that's all for the person that has rabies bite, yes?
No, you also have to give anti-tetanus because it's a wound too. Because that might not be the only risk that the person has. So you still give anti-tetanus.
Okay.
I think it used to be TT, but now it's being given as I think TDA, tetanus with acellular diphtheria. So I don't know if I've answered your question.
Yeah, thank you.
Okay. Okay, so we move to the next one. So I want to see if we can carry, maybe do two more. So okay, so what vector is this? Can we recognize it?
Rhizotomos sandfly,
Okay, phlebotomous species. So what disease does it cause?
leishmaniasis,
Okay, thank you. So this is the phlebotomous species, also referred to as the sandfly. So I don't know, are there features that stand out for you that you think will help you recognize it if you see it? Let's say you're giving a picture or something. So I know some of your exams come out as pictures, and all. So for this one, basically, what you can use to recognize it are, one, if you see these long legs, you see that generally this vector is hairy, both the wings, the body, the legs. The vector is just hairy, and then it has what is characteristically referred to as the angel wings, that such that the wings are held as a position referred to as angel wings. So I just try to bring the various forms for us to see. This one has taken a blood meal, this one has taken a blood meal, but these two, they haven't taken blood meal. But then if you look at it, you can still recognize it. It's quite hairy, almost transparent. Then this angel wings position is a way to recognize them. So I wouldn't bore us too much with it, but one, characteristically the angel wings, then the hairy appearance, also referred to as the sandfly. They are tiny flies measuring just about 1 to 2 millimeter. They cause leishmaniasis, and leishmaniasis can be cutaneous or visceral. I think the cutaneous is referred to as the oriental, but please kindly check it up. But the visceral is the calaza. So this one affects viscera like liver, and all. So I just included a note for those that may want to read more, but I don't want to bore us too much with it. Okay, worthy of note is that the visceral leishmaniasis can lead to a complication known as the post-calaza dermal leishmaniasis. So even after the person has been healed, this person can come down with this complication, and this person can still transmit the disease despite being cured. So I don't know if it was your set. Now we talked about various groups of carriers. We talked about the convalescent carriers, the healthy carriers, the incubatory carriers, and the paradoxical carriers. you know. So in the sense that they themselves, in quotes, do not have the disease or are not manifesting the disease, but are able to transmit the disease. So for the convalescent carrier, the person is already recovering, which is more like the case of what you have here. Then there's the healthy carrier, something like typhoid fever, salmonellosis, Mary typhoid fever, and that's why Mary typhoid was able to successfully infect so many people. She was a healthy carrier. That is because the organism can live in the gallbladder for years and a person will keep shedding it. Sorry, I know it's just a digression, but something to take note of. Then the incubatory carrier. The incubatory carrier in diseases like, so sorry about that, diseases like polio could have incubatory carriers, which means they've been infected, they are yet to manifest the disease, they are not yet sick, they are still in the incubatory phase, but they have started transmitting. In fact, for polio, you could have convalescent carrier, you could have incubatory carrier. I can't remember any example of paradoxical carrier now. So just to take note of that, peradventure you come across any question like that. So this is the black fly. The black fly, also known as this is Simulium species. Remember earlier on when we were talking about the water-related diseases, and we're talking of the water arthropod borne, where the arthropod breathes in or lives near water, and I said that the black fly breathes in fast-flowing water and leads to transmits onchocerca volvulus, which causes onchocerciasis or river blindness. So at times you have people living along those kind of fast-flowing waters having the blindness. So that's why it became it got to be referred to as river blindness. So this is what it looks like. It's actually a small fly too. No, I didn't post another image of it, but basically when you see it, it's quite smallish. It looks plump. The abdomen looks plump, and then it has that dark hue. So that would help you recognize it. This is a lot different from the what do you call it now? The phlebotomos we talked about earlier on. So this leads to onchocerciasis. So I just added a small note there, which you can refer to later on. And worthy of note is the onchocerca control program, which started around 1974. I think it included just about four African countries or something, but it helped to successfully control onchocerca. So it was later expanded to involve more countries and was later referred to the African program on onchocerca control, something APCO or something like that, in 1998 or so. So just have that in mind. Basically, just simple basic stuff. Black fly, also known as Simulium species, transmits onchocerca volvulus, which leads to onchocerciasis, which is synonymous to river blindness. I think that's more than enough. So I don't know whether Dr. Paco, do we end here? We're actually 19 minutes late, or should we just
Okay, let's just finish this slide, then we end it for today.
Okay.
Okay, let's just finish this current slide, then end for today.
Okay, so what comes to mind when we see this histology slide? Sorry, not a histology slide. When we see this blood film, this is a thin smear.
Can I answer?
Hello?
We can't see the blood film yet.
Can I answer? Do you want someone to answer?
Okay, it's on display now.
Do you want someone to
Can you
answer?
see it now?
You can answer.
Okay.
Yes, we can see it.
Okay.
So maybe you can zoom your screen. Your screen. If you can't see properly, just zoom your screen. You can fit on your screen.
So, malaria diagnosis, we know that you can use rapid test or you can use microscopy, right? Well, we have many RDTs available now, you know, especially for the species, which is the most implicated in our region. So I think I would want to ask, like, what are the various species of Plasmodium we know?
Can I answer? Hello?
Plasmodium ovale, vivax, falciparum, and melissa.
Okay, I got Vivas, I got
Hello? Can anybody
Falciparum.
hear me? Can I answer?
Yes, yes, please
Answer.
go ahead.
There is Nolesi,
Okay,
Ovale, Vivas, malaria, and falciparum.
thank you so much. Okay. I know most of us are familiar with the falciparum, but actually there are other species like she has mentioned. And so for the diagnosis, we can do RDT, we can do microscopy. For the microscopy, it can be a thin, Giemsa stain, thin or thick blood film. So for the thick, you can only say whether you can only do a count and say whether the person is infected or not. But for thin, you can do species identification, or what they call, is it specification, like you can say whether is it falciparum or not. Okay. That is a major difference between the kind of information you can get from the thick or the thin. But basically, if you see this kind of film, just to play safe, if you can, if you don't want to, if you want to play safe, yes, you can just say malaria parasite on blood film or something. But if you look at this, what we are actually seeing are the ring form of the malaria parasites. So you can be specific and say the ring form, and this ring form is the erythrocytic stage. So you can be that specific and refer to it. But what we have here is malaria parasites in the red blood cells. So what is the standard for treatment of malaria? Because I'm sure there are additional questions that can come out of this particular picture. Standard for treatment. Okay, let me just say for simple malaria.
Acetaminophen combination therapy.
Sorry, please, can you repeat yourself? I didn't get that.
I said acetaminophen combination therapy.
Thank you. That's the ACT. Okay. So that is the standard for treatment of
We can't hear you anymore.
So sorry, my
So
phone is
sorry, my
beginning
phone is
to.
beginning to. Phone is beginning to.
Sorry, I didn't get the
Sorry, I didn't
question.
get the question. I didn't get the question.
We can't hear
Hello?
you. We can hear you now.
Okay, sorry, my phone went off. Okay. So yes, so it's the ACT, and then there's something that is ongoing, some kind of my phone is beginning to some kind of what do you call it now? Chemoprophylaxis. It started more in the north, but I think it's being scaled up presently. So we also have what you have noticed that we also have chemoprophylaxis for malaria going on now. I think it has I'll try and drop the components on the page once we are done. But then very uniquely about this chemoprophylaxis is that it's the person, yes, the idea is that the person shouldn't have the disease before you give the chemoprophylaxis. So ideally it is given during this raining season, and depending on the area where you live, is given based on the length of the raining season. For some places they might take for 3 months, for some other places they might take for up to 5 months, depending on the length. Depending on the length of the rainy season in those places. For what happens is that for each month they take for 3 consecutive days. Then the next month 3 consecutive days, like that, for either 3 months or even up to 5 months. And that it is the dosage is enough to treat. Peradventure the person is even infected and you did not know before given. It's not a suboptimal dose, but that dose is also able to treat if the person peradventure has malaria at the point at which you are giving the chemoprophylaxis. But the aim is not to use it to treat, but is that for somebody who does not have, you are using it as chemoprophylaxis. And then we should also know that there's also there's also a WHO approved malaria vaccine now in that's undergone several research and is being tried out too in it's been approved for use now. So those are things to take note of. So basically, I'm going to drop 2 things on the page. I can't remember the name of
I can't remember
the vaccine now. And then I'll drop the components of the chemoprophylaxis for us. Peradventure, it gets to that point. Sorry, I think we may have to stop here. I'm hotspotting both with my phone and also using it, so it's overheating. So we may have to stop here. Then we'll continue tomorrow, and then I'll share the slides with us. It's actually a part 1 this thing, but I think it can be helpful. Just pick the basic. Don't bother yourself about too much details from me. Just pick the basic. I think that'll be all. Thank you, Dr. Parker. I think that'll be all.